We are recording and participants are coming in.
Good morning, everyone who's coming in. We'll get started in just a moment. We'll begin in just a moment as soon as some of the other participants can get into the call. Well, good morning, Forsyth County. Welcome to this virtual forum on COVID-19 and the health insurance coverage gap in Forsyth County. I am Peg O'Connell, and I'm the chair of Care for Carolina, the coalition that's working to close the coverage gap in North Carolina. It is my great pleasure to say thank you to the two co-hosts that we have for this virtual forum, which will be the last of 12 virtual forums that we've done across the state. So a big shout out and thanks to the American Heart Association for co-hosting this event and to the Partnership for Prosperity. So Paula, representing the Partnership for Prosperity, would you just like to say a few words of welcome to folks?
Yes, welcome to this forum in Forsyth County. And just a little bit about the Partnership for Prosperity. It's an initiative that grew out of a group convened by our Mayor Alan Jones. It's called the Winston-Salem Poverty Thought Force, and that was in February of 2017. But the partnership it was formed to help fight poverty, to raise public awareness, and to advocate for policy changes on a local and state level. So we just work with low resource neighborhoods, helping them to connect and find the resources that they need from the organizations that exist here. We engage our residents, particularly those with lived experiences around the issues that they are faced with daily. And so health and wellness is one of those, which is why I'm particularly interested in this issue. Our mission is to align resources and to eliminate silos and advocate for policies through a racial equity lens that help our most vulnerable citizens. And so we want them to thrive and we want them to be healthy. And so we are glad to be a part of this important discussion today.
Thank you, Paula. And I have to say, Paula had about 2.5 weeks ago, a knockout op-ed in the Winston-Salem Journal. So you all will get a link to that if you haven't seen it, and I highly recommend it to you. So thank you, Paula, for being a part of this effort. Next, it is my pleasure to introduce, first, I'm sorry, before I call on you, I just want to give you a couple of housekeeping details. So all of the participants will be on mute, except for those of you who are speaking today. And then, so if you have questions, put them in the chat box, or at the bottom of your screen, you will see participants. You can click on that, and that will bring up all the people that are on the conference, and you can actually raise your hand. We can unmute you, and you can speak. But we'll save all of that until the end. So we'll let the presenters make their presentations, and then we'll open it up for what I hope will be a robust community forum. So, Mark, without further ado, it is my pleasure to introduce to you Mark Hall, who is a professor at the law school and public health at Wake Forest University. And Mark has been a longtime partner with Care for Carolina and did much of the work around which we formed our coalition as far as the impact of closing the coverage gap, the benefits it would bring to veterans, the benefits it would bring to North Carolina, and what other states are experiencing. So Mark, if you will talk a little bit to us about what you know and what you have seen.
Okay, glad to, thank you. I'm going to start simply by just, describing what is the coverage gap and its significance. I'm guessing that everybody on the call knows this issue well and is in favor of closing the gap. But others may watch this recording, and I want to be sure everybody's clear on the facts and the consequences. So the phrase, the title just popped in my head. But next. So this is a quick pictorial of what is the coverage gap. The blue lines are the categories of traditional Medicaid coverage, which are pretty generous for pregnant women and children, and decent for those who are elderly or disabled. But for others who are parents and have children, or just other adults, traditional Medicaid tends to be very stingy. And so it's this difference in these categories that the ACA was aiming to eliminate, and to sort of raise all the boats to the same level, so to speak. And so the orange is the categories that were underfunded that the ACA pays to lift the boat up to this level of 138% of poverty. Next slide. So, back. Yeah, so the green bars show if you're not on Medicaid, the ACA exchange has highly subsidized coverage at the lower to middle income, and less subsidized, sliding scale up to 4 times the poverty level. But the design of the ACA was always that Medicaid would cover up to the point where the subsidized exchanges start. And it was a surprise to everyone when the Supreme Court said that states had the option to decline Medicaid expansion. And that's what created the coverage gap, because the ACA was not written to cause the exchanges to lower their threshold in these non-expanding states. So that sort of gap created by the design of the ACA, coupled with the Supreme Court's decision, and then sort of the inexplicable decision by a number of states not to expand, is what leaves us with this gap. So if next. So this shows the gap horizontally rather than vertically, and it gives a bit more of the numbers. But in terms of real numbers, families with children are covered by Medicaid up to about 45% of poverty, 40-something. That's roughly $9,000 for a family of 3. But if you earn more than that, you get no help until you earn $12,000, and then you get help on the exchange. So you have this weird effect that those who earn less get less help. Next. The irony that you know, hundreds of thousands of us earn too little to get the extra help. Next. So this is simply a map that shows how many in the Piedmont Triad area. That's 2,400 people, which is sizable. But oh, I'm sorry. So who makes up these numbers? Well, it's, you know, everybody you know who doesn't earn more than $12,000 for a single person. Sorry, for family of 4, that'd be 48,000. So lots of, you know, families earn less than that but don't qualify for Medicaid, and hardworking folks and what have you. It also includes folks like veterans who just sort of fall in this lower middle income area, and just you know, next. And in terms of the coverage gap, the numbers are going to increase significantly because of COVID, because COVID hits everyone, but it hits especially hard folks who are non-professionals, who are earning, you know, the part-time workers, or service workers, or people like that, or minimum wage workers who earn enough to not qualify for Medicaid, but not enough to be on the gap, and you know, by those who lose their job-based insurance are going to be thrown more into the gap. And this is a map that sort of shows the job effects of COVID, but the estimates are that at least 175,000 additional folks will fall into the gap because of COVID, on top of the ones already in the gap. And so we're now looking at the potential that expansion would help cover people up to perhaps 500,000 people. The ones who currently fall in the gap, plus what's known as the woodwork effect, that if you bring more highlight and attention to Medicaid and make it easier, you'll have some additional people who are uninsured sign up. And so depending on what estimates you make about the cumulative effects, we're talking about hundreds of thousands, of, you know, roughly 500,000. Next. So, you know, what are the benefits of expanding Medicaid, or getting coverage, of covering the uninsured? Well, they're numerous, and it's still, you hear the absurd argument that, well, you know, it's really Medicaid isn't that good. Well, people who don't like insurance, I welcome you to give up your insurance card if you think insurance isn't that helpful. I mean, everybody acknowledges how helpful insurance is, and you know, it's hard to find the study that says that it's, you know, maybe a break-in proposition. So the green colored bars show how many studies show positive benefits, and the blue colored bars show studies that are more equivocal. And so, yeah, okay, you can find a few equivocal studies, but the dominant evidence is obviously that this helps people in numerous ways in their life and welfare. But unfortunately, that's not enough to sort of make the case. So instead, next, we have to talk about the economic benefits. And the most important point here is that expansion is almost fully paid for by federal dollars. So 9 out of 10 of the dollars comes Fed. This only shows 8 out of 9 because, again, this would work effect that there'd be some impact on the existing Medicaid funding, which is only funded 2-to-1 by the feds, but the rest of the expansion is 9-to-1. So if you average it out, it's 8-to-1. But either way you look at it, it's a great deal. Next. So the point about this great deal is not only are you turning down this great opportunity to sort of make your money go 9 times further, but you're leaving on the table the money that we as taxpayers have already paid. So you're really, you know, cutting off your nose to spite your face, but I have shooting yourself in the foot. It's really an economic, you know, self-inflicted wound is the point. Next. And so this is an older graph, but it just simply shows the states that did expand are basically leaving money on the table. The taxes imposed by the ACA are in place, there for the taking. And by not expanding, you're just simply foregoing the money that we are paying as taxpayers, which is just seems completely idiotic. But this is a depiction of the states that are choosing to make that decision. Next. And so here's a tracker that the I forget which advocacy group the Justice Center runs. It sort of, you can click on it and it ticks by every few seconds the number of billions of dollars that we've foregone of our tax-paid money, the federal money that we've declined to receive back. Next. And this gap between the haves and the have-not in terms of getting your fair share of federal money will increase with COVID funding. So with the CARES Act and such that sort of puts more money into the healthcare system, a lot of that is matched onto the Medicaid program. And so states that didn't expand will get less than their share of the COVID money. Next. In addition, there's all sorts of benefits besides just direct funding to Medicaid. There's you reduce the amount that our prison system has to pay for prison health care. You cover a lot of the things that the county public health departments already have to do out of other funds, now get covered by Medicaid. Similarly, for our expensive substance abuse mental health programs that are county and state funded, a lot of that gets picked up by Medicaid and other sort of specialized, more localized safety net programs for the uninsured. So hospitals that are having to carry the burden of this uncompensated care would have all that greatly relieved, and some amount of that burden is borne by taxpayers. So that's sort of direct economic benefits of funding. And then we have the macroeconomic benefits, the stimulus effect next. And the stimulus effect is all according to, I don't want to say trickle down, I want to say multiplier effect. So you put, you know, $1 in the economy and it funds a job, and that creates, you know, more purchasing, and all these transactions multiply out in terms of stimulating the economy, not sort of just in terms of creating jobs and economic welfare, but also dollars and cents in the public purse, because all those transactions, all those wages, what have you, are taxable. And so like any other sort of, you know, the government spends money to bring, you know, manufacturing or whatever sort of job stimulus money into the state because of the return to the public taxpayer, to the tax base that occurs here. Next. And so if you ask the question, do states regret expanding Medicaid? Resounding no. I mean, next. You know, so you simply look, all the ones that have expanded, 30 some odd, have any rescinded? No. And so these include a number of, you know, purple or pretty deeply red states that, you know, said it makes perfect sense to expand, and there's no sort of oops, we wish we hadn't, or much less they have the power to, rescind or retract. So there's just no buyer's regret, issue here. Next. And it isn't just speculation. Originally, it was sort of projections. If you expand, you'll get all these compensating benefits. But now we have state after state that has done this, and we've studied this over and over again. And again, this is a literature review synthesis of the number of studies that show positive economic effects, and a few studies that show more equivocal effects. And so, but overwhelmingly positive effects. Next. And we could go on state after state of, specific hundreds of millions of, tens or hundreds of millions of dollars saved. And this just sort of breeze through these charts that are in the literature, and you can look at your leisure, but these are savings to the traditional Medicaid program, the sort of spillover benefits that we articulated add up to tens or hundreds of millions of dollars. Next. And these are more of the, outside of Medicaid, the other effects of other parts of government spending that are reduced by Medicaid expansion in the tens of millions of dollars, and hard quantified money in states that actually expanded. Next. And Virginia, just nearby, actually came out ahead because they anticipated a certain amount of money for their expansion, and they actually paid for that through a tax on hospitals and providers. But because the spillover effects, the positives that we just noted actually fully paid for the expansion, so they didn't need that provider tax, so they came out ahead. They have a giant surplus, at least that's what's being projected in terms of their state budget, due to basically the expansion paying for itself, and what have you. So next. So the rest of my talk is simply to take these well-established points that we've seen in other states that have been projected for North Carolina statewide, and see how they would apply here in Forsyth County in the Triad. And this is a study done by, funded by the folks shown here, and done at the George Washington Health Policy Institute, which is highly respected. Next. But more importantly, they use standard macroeconomic modeling. That's this model called REMI for something or other that's used by a lot of sort of very careful number crunching, sort of conservative estimators, such as the U.S. Congressional Budget Office and various other sort of government budgeting officials. So it's not some, liberal wide-eyed, geez, let's just, optimistically assume everything comes out fine, but it's a very widely used, highly, well-regarded next, primo on the money estimator. Next. So these are jobs, estimated jobs that will be created by expansion, and I think it adds up to 40-something thousand. But here in our area, you can see it would be some 7,000 jobs. Just because you put money into healthcare, you're going to have more people hired. So next. Doing that will create additional tax revenue in the billions of dollars, and we're looking at 1.6 billion is the estimate in this area. Next. I'm sorry, that's not tax dollars, that's economic growth. And so just the additional jobs creates more spending, and so that's sort of gross state domestic product, I guess. So this would be the additional tax revenue that would come from that additional economic activity would be in the dozens of millions, I guess, getting close to 100 million, but some 22 million in this area. Next. And so this gets a little bit more concrete for these two counties. So these are jobs estimated approaching 5,000 jobs in Forsyth and Guilford. The economic impact estimated being at over $1 billion, and the increased tax 12.7 million. So if you want to take it from the general region of the state to our specific counties, there are those numbers as well. Next. And so we asked the question to conclude, is there any reason that we would think that North Carolina would regret expanding Medicaid? I would think it would be hugely unlikely. Next. But do we currently regret not having expanded it? Well, I certainly do, but it depends on who you ask. And next. According to some folks, we don't, but we always have to ask that question and say, according to who we hear from in terms of the issues that are important to us and the constituencies that we feel like should have a voice, do we regret having not expanded? And I certainly think the answer is yes. Thank you.
Thank you, Mark. I have to tell you, I love that last slide. We might save that. So thank you very much. That was a very, very well done presentation. And for those of you who are not sure about who these people are, I would venture to guess, Mark, that this was a picture of the signing of some bill that probably did not do the public health very much good. So, and that is former Governor McCrory right there. So our next speaker is going to be Dr. Jamie Ard. Dr. Ard is a professor of epidemiology. He is a physician and an epidemiologist and focuses on epidemiology and prevention at Wake Forest School of Medicine. So for those of you who are from Forsyth County, this is a very local presentation, and we wanted to make sure that the voices in your community were heard from. So Dr. Ard, I know you're also very active with the American Heart Association. Please take us through what you know about what's going on in your county and in our country.
Thank you, Peg. I appreciate the opportunity to participate in this forum today. I was asked to lend my voice to the conversation about the perspectives on health disparities. And as I thought about what I might present, it struck me that even though everyone is focused on the disparities that have been highlighted by the current pandemic, disparities in health have been around for a long time. A lot of my research focuses on addressing many of these disparities that have come to simply accept as fact of life. But the question that has stuck with me as I was preparing this talk is, why does the most advanced country in the world have such poor health outcomes for some segments of its population? Where did this come from and how did we get here? Next slide. So I'll start with this quote by James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it is faced. Next slide. From the birth of this nation to present day, Blacks and other disadvantaged groups have endured health outcomes that are generally worse than those of advantaged whites. History shows that the disparities in health outcomes we observe are not by happenstance, and I'll argue that they are actually the result of intentional decisions designed to limit access to health care. There have been several examples throughout history that illustrate this point, starting from slavery right down to the current pandemic of COVID-19. Next slide. In the next couple of slides, what I've done is just pull together some statistics to highlight some of these disparities that I think about or deal with on a regular basis, both from a clinical standpoint as well as from a research standpoint. These are just a few of the examples that we could talk about all day. However, I won't dwell on them except to say that they do exist for people of color and those in lower socioeconomic groups. What you see here is an example of the disparities in type 2 diabetes. Next slide. For Forsyth County, we also have a significant difference in the amount of preventable death from cardiovascular disease and stroke for individuals who are Black or African American. Next slide. And finally, something I deal with on a regular basis with my team is obesity. And we can see at the top and in the right-hand panel, differences in the prevalence of obesity for individuals who are Black or Hispanic, Latina, Latinx. Next slide. So if we think about, as I started to think about the search for answers to my question on Why does the most advanced country in the world have such poor health outcomes for some segments of its population, and where these came from? It took me back to the beginning of Blacks' existence in this country. Understanding how, quote unquote, healthcare was approached for slaves is actually very informative for framing that current context. Next slide. The slave owner's perspective was to keep his investment safe while providing the bare minimum required to do so. Typical rations that were provided by a slave owner are shown here, and they were basically sustenance. Those rations were supplemented by what could be grown or caught, and then an individual slave tried to put together basically sustenance nutrition. Conditions on plantations foster spread of infectious diseases and parasites, and the nutritional status increased the susceptibility to those diseases. Unfortunately, this was further compounded by the prejudices of physicians. Next slide. As the status of American physicians increased in the early colonies, they became central figures in providing evidence of the inferiority of Blacks through pseudoscience. However, they ignored the basic tenets of science that they had professed to promote, ignoring the cause and effect of poor conditions and undernutrition. They created diseases that were peculiar, quote unquote, to Blacks, such as Cachexia africana, which is dirt eating. Now we know this is simply pica and is a result of iron deficiency anemia. However, they treated it in a very cruel way, placing iron mask or other implements that limited the slave's ability to consume the clay. Next slide. If we move forward to the Reconstruction era, Congress now creates the Freedmen's Bureau. And the Freedmen's Bureau was designed to address needs of free Blacks and poor whites in the South. Healthcare eventually became a part of that mission. Blacks suffered disproportionately from disease outbreaks in their encampments. Those diseases included smallpox, yellow fever, and cholera. And even though legislators knew the benefits of sanitation and quarantining, even back then, freed slaves were not assisted in managing those outbreaks. And as you might expect, mortality was extraordinarily high. Next slide. The rationale for willfully ignoring these problems was twofold. First, they wanted to keep the infection from spreading into white communities. And secondly, they said that providing assistance to freed slaves would only breed dependence. Where have we heard that? Ultimately, the ruling class felt that a healthy Negro population would upend the social order. Therefore, in this case, disease was weaponized to limit the ability of the freed slaves to pursue the tenets that were promised for all Americans: life, liberty, and the pursuit of happiness. Next slide. So as perverse as this sounds, it just became internalized. If you repeat something often enough, it becomes internalized and reframed as Blacks simply being inferior and inevitably aided to poor outcomes. The prevailing theory was that the Black race was genetically predisposed to poverty and unhealthy living conditions, leading to high morbidity and mortality. This completely ignored the social circumstances that existed to create those very conditions. Practically, what this meant, especially from a disparities perspective, is that if you were an individual who was Black, you were not insurable. Life insurance was not accessible to Blacks because many actuaries actually believed that the Black race would go extinct by the late 1900s. Next slide. I found this quote to be very interesting. It could be said that the life insurance industry came full circle for African Americans, who were the first to be insured for the wrong reasons and the last to be insured for the right ones. Next slide. As we move forward in history, we see the South rise post-construction, post-Reconstruction, to cement a segregated society as a way of life. The Southern states start to consolidate their influence in the voting bloc that helps to limit federal oversight and maintain states' rights. Segregation had a direct influence on Blacks' ability to access healthcare systems and achieve healthfulness. Next slide. One example of how this power directly affected disparities was the Hill-Burton Act, passed in 1946. This act provided construction grants and loans to communities that could demonstrate viability based on population and per capita income in the building of healthcare facilities. By the turn of the century, this act alone was responsible for 6,800 facilities across 4,000 communities that had in some way been financed by this law. As a bipartisan law, it codified the idea of separate but equal in hospitals and healthcare facilities because segregationist votes were needed to pass this legislation. They exacted the compromise that each locality could maintain segregated facilities if desired. So how does this relate to disparities? Well, just one quote I think helps clarify this. The president of the National Medical Association, which is the nation's oldest and largest organization of Black physicians, said in an address in 1962, he explained that racial discrimination in medical services and facilities was understood to, quote, be one of the prime reasons why Negro infant mortality is from 2 to 5 times greater than white infant mortality, why white women are 5 times less likely to die in childbirth than Negro women, and why Negro life expectancy is almost 7 years less than white life expectancy. A lot of these statistics haven't changed. Next slide. For a bit of local history, a group of dentists and physicians from Greensboro sued Moses Cone Hospital to gain access to that facility for their patients and themselves. And ultimately, they prevailed in 1963. Their victory outlawed the idea of racially segregated healthcare. Although, I will point out, as the slide shows, it took a little bit of time before Cone Health was actually apologized for this policy. Next slide. If we go back to another point in time in the post-Reconstruction era, we can see another major development in healthcare that also contributes to health disparities. Before World War II, as medical care was starting to become more accepted, hospital-based care as well, hospitals and physicians, they needed a better way to really get paid more consistently than just by wealthy individuals, wealthy patrons. So during World War II, labor shortages caused intense competition for work, and there was a wage freeze enacted to avoid inflation in wages. Companies figured out that they can incentivize recruitment by offering health insurance as a benefit to potential employees. Later on, the IRS made these benefits exempt from taxation. The result is that health insurance now becomes accessible, but only if you can acquire it through a job. And so employer-based insurance is now born. If you didn't have insurance through your employer, or you weren't a wealthy individual who could afford to pay for your health care, then you didn't have access. Next slide. So what we have is a development where insurance through employment becomes the norm, but if companies discriminate against individuals of color, decreasing their opportunities to be employed, Blacks often worked in positions where health insurance was just not a benefit. Therefore, Blacks were kept out of the health insurance market through no fault of their own. And next slide. Without insurance coverage, healthcare was a remedy of last resort, leading to what you might expect, poor health outcomes driven by increased prevalence of preventable disease. Even when Blacks could get employed in positions that offered health benefits, they only had limited access to healthcare as a result of discrimination. Remember the Hill-Burton Act. So today, I would argue that many of the same forces are at play, and most uninsured are working individuals, as you heard Mark talk about, who do not have the fortune of working at a company that can provide insurance as a benefit. Next slide. So now as we move to 2019 and 2020, and we have a different way of thinking about race and factors that influence health outcomes. We know that important factors like access to healthcare have a direct impact on health outcomes. Even though we understand this, we still have a difficult time moving away from what has been a very entrenched way of thinking about health. Individuals just need to take personal responsibility. If assistance is provided, it will breed dependence. Even though the odds may be stacked against you, if you just work hard enough, pull yourself up by your bootstraps, you will get access. Meanwhile, most people don't have boots anymore. Next slide. Let me just walk you through some of the data from our county about the impact of COVID and the disparities that we are seeing. So this is from the North Carolina, from the COVID tracking site that looks at our disparities in COVID. And you can see that nationwide, Blacks are dying at 2.3 times the rate of whites. Next slide. In North Carolina, you can see that there's a disparity in the percentage of deaths compared to the percentage of individuals in the population, with a 9% higher percentage of deaths for African American compared to their percentage in the population. Meanwhile, fewer whites are dying as well as Asians. Next slide. Forsyth County in particular has a very high rate of positive tests for individuals who are of Hispanic Latinx background. Next slide. Why do we see these COVID disparities? Well, COVID has shown a bright spotlight on a sore spot that we have not taken seriously. This pandemic has highlighted the life and death consequences of our inability to protect the most vulnerable in our society, individuals who are frontline workers, individuals who live in multi-generational households, individuals who have fewer personal resources for protective equipment, and individuals who are more likely to be uninsured or underinsured. Next slide. So I come back to our opening quote by James Baldwin. We now face a history. We're now face to face with this history, and its tentacles continue to reach into our present day, keeping us mired down in the same way of doing things, but hoping for a different outcome. What will we do? Next. While times have changed and there are no overt efforts to create separate healthcare facilities or exclude individuals who are non-white, many of our decisions about who should have access to healthcare resemble our actions of the past. So to me, it should come as no surprise that the least advantaged among us suffer the most from poor health and are most vulnerable during crises like COVID-19. Next slide. So if we are face to face with this history and we look in this mirror and see our reflection, we've had multiple opportunities throughout our history to do the right thing, and we've consistently chosen to deny healthcare to the most vulnerable. I think this is an opportunity for us to do something different for the citizens of North Carolina. Thank you.
Whoa, thank you, Dr. Ard. That was just remarkable. Thank you very, very much. So I'm usually not speechless, but you have left me without words. And I hope you guys are not getting the same weird sound that I am. So I'll stop talking in a moment. Now, I am glad to introduce to you Cindy Gordinier. She's the president and CEO of the United Way of Forsyth County, and she's going to talk to us about what is happening in the local community. I think both Mark and Jamie have given us some good insight into what's going on in Forsyth County. But Cindy, please tell us what's going on the ground there.
Thank you, Peg, and good morning, everyone. I'm happy to be with you this morning. Both of my fellow panelists, Dr. Ard and Dr. Hall, have talked about the data around both the historical and the economic impact of health disparities, lack of health access. And I want to take it down to the micro level because for a family without health coverage, the problem isn't theoretical. It is a real problem that faces them every single day. And it has an impact on not just their health, but other parts of their life as well. So we are talking about, as both Dr. Hall and Dr. Ard referenced, the working poor, people who go to work every day, but don't get benefits through their jobs. And so are maintaining a life without any access to health coverage, and the impact that that has on their life is profound. So the other thing that we have to recognize, and this has been mentioned several times around the recent COVID, the pandemic, is even folks who may have had access to health insurance through their jobs have seen jobs go away. And so we have a significant number of people who were covered before March and who are not at this time, on top of the many, many people in our community who didn't have health care before March and still don't. And so the loss due of health coverage due to the job losses is also a critical factor for our community. And that would be mitigated by an expansion of Medicaid in our community and in our state. So I think the argument's been made, but I really want to have you think about how it affects a family and in real time. So when we talk about health and the health of the family, whether it's the adults or children, what a lack of access to health coverage means that medical needs are put off, or that care isn't sought at all, meaning small issues are not addressed until they become significant health challenges. So if you think about it, you send a child to school with an earache because you don't have insurance to take them to the doctor, or they go with strep throat and they are now contaminating other children, and communicable disease is spreading. So it is affecting others in our community. So it's not just personal health, but it becomes a community health matter as well when someone's moving about with a communicable disease that could have been treated easily if they had access to health coverage. Adults go to work sick, and even something as simple as a policy that says you can't return to work after 3 days unless you have a doctor's note. If you don't have a doctor, it's difficult to get that note. And so you go back before you would need it, even if you're still sick, even if you might still be infectious, because you need to. And you've already lost a day or two of work. To go out and seek medical care is one more cost burden that you just can't absorb. So you also have a lack of preventable treatments, or preventative treatments, sorry. So things like physicals, screenings, even flu shots. So in this particular year, when we're talking about the flu being something that we want to be incredibly careful about because of the concern for it, a strong flu season on top of the pandemic, for those who don't have coverage, access to a flu shot is really not a possibility. Those who have children who may have a health condition, they have no place to turn for reassurance or for assistance. So if you have a child who seems to not be well or seems to be exhibiting a symptom of something that you're not sure about, for those of us who are lucky enough to have health coverage, we call our doctor and we take the child in and we have them checked. For a family who doesn't have that, so for both an adult or a child, you don't have the ability to seek reassurance that something isn't terribly wrong or something that needs to be addressed is present. So there's another reason that an expansion of Medicaid for a family would be a great boon to them. When medical care is sought, it is often through either emergency rooms or free clinics, which means there isn't a continuity of health care. So small indicators get missed. And so often something that, you know, if you go see your own regular doctor, they may say, well, that wasn't present last time. We need to do a little, you know, testing to find out what this is. That's not going to happen when you're moving from through a healthcare system that has no sense of continuity for you. And that is going to be the reality if you don't have health coverage. Often only emergency healthcare issues are going to get treated. So the chronic issues that really you know, are ongoing and don't need to turn into emergency issues are not addressed. And really the healthcare system never sees you until it becomes an emergency. Mental health is a growing issue for our society. We see that. We also know that there are huge disparities in mental health access, and an expansion would allow those who right now do not have coverage, and it's those folks that are in that gap between low enough income that they have coverage today and income that would allow them to be able to access coverage through the ACA market. So you saw that gap that was in Dr. Hall's presentation, and it's that group right there who are under a great deal of stress in their daily living and do not have access to any mental health treatments or coverage at this point in time. Substance abuse, right, they has no access to coverage. So those who have some kind of substance abuse issues or even have the beginnings of such, and if that's allowed to continue, can derail someone for a lifetime. That is not something that people without coverage are able to even think about. And so that just is allowed to continue and to grow and potentially can turn into something that changes a life for both that individual and a family over the long term. So those are all things that have an impact on health. And so those are direct impact things that without health coverage, those are the types of issues that are going to arise in your family, in yourself, in your children. And so those are pretty important, but they're also things that you may think of on your own. Let me talk about the things that are also impacted by a lack of access to health coverage that aren't quite as obvious. So all of the challenges in the life of the working poor are interconnected. You can't separate out health from housing, from education. These things are all connected. And so let me give you a little bit of an example of what I mean by that. Households who don't have health coverage are also struggling to pay for other basic needs. They have a very carefully built payment schedule to be able to stay housed and to make sure there's food on the table. An unexpected medical bill blows that carefully constructed schedule apart. And so they are not going to be able to absorb the cost of a medical emergency or even just a regular visit or a flu shot without a disruption to the rest of their bills. And that means that can become an issue that ends up in other bigger issues in the family. So 41% of North Carolinians have reported that they don't set aside any money for emergencies. 41%. So an unexpected medical bill is going to take that budget and create havoc within it. So what happens when you do access the healthcare system and you've got that very carefully constructed budget that does not allow for medical emergencies or medical needs? You may not fill the prescriptions, even if you did go to the doctor, or refill them after the first time because of the cost. So in a tight budget, everything is a trade-off. Medical bills also are going to mean that other bills will be deferred. And so if you have no savings, you have to trade off one bill for another. It can mean that you don't pay your rent on time. Right now, in Forsyth County, almost 26% of our residents spend more than 35% of their income on housing. So 35% of their income is going towards housing. And if that has to be deferred in order to pay for a bill, a medical bill that wasn't expected, they are going to face potential eviction down the road because they haven't kept up on the rent payment or the mortgage payment. We have a number of families or households in Forsyth County who spend more than 50% of their income on housing. So keeping housed is a significant challenge, and one unexpected bill can cause that to be shifted or make it impossible to keep the housing you have. What that can mean is that if you aren't evicted, if you move more quickly than waiting for eviction, it may mean that you have to search for a less expensive and usually more substandard housing option. That housing option is probably going to be less safe and less healthy for you and for your family. And so each of those, the kind of the way that this works across, it's a wave across the budget for a family who right now falls within that gap in that Dr. Hall showed in their level of income. When a family has to move, usually children have to change schools. There's a disruption to the children's education. So it has significant reverberating effects across all aspects of a family's life. It isn't just about, can you go to the doctor when you have a sore throat? It's about what other choices are going to have to be made if you have to go to the doctor and you don't have coverage. And those of us who are lucky enough, have the luxury of having health insurance, don't think about that it's not just about the health coverage. It's about all the other impacts on your life. Equity in our community is a significant challenge, and inequity is present across all aspects of our community. But in the current environment with COVID, we have seen those disparities grow. They've been exacerbated. And so when we already had significant health disparities, we already had significant disparities of all types, the COVID has exacerbated them, and not having access to health insurance has made that even more of an impact than it needed to be or would have been if North Carolina had chosen to expand our Medicaid access when it was available to us at first. And so families are struggling in our community, are struggling in Forsyth County because North Carolina has made the decision not to expand access to Medicaid. And this is an important issue that I ask you to step forward with us to address because it needs to change. Thank you.
Cindy, thank you very, very much. Haley advised me that we have someone who can't stay for the entire program, but who has a question. And we asked if that person wants to raise their hand or put it in the chat box. We'd be happy to open up the mics before Sarah takes us to our policy options. Anybody? All right, I'm not seeing it. Okay, well, if it pops up, we want to make sure that everybody gets their chance to ask and have their questions answered. So wait a minute. Tanisha Dist. The mic is open, please. Tanisha, please.
Yes, first of all, I want to say this is a very informative and very important session for me, and I thank my friend for inviting me. Can you all hear me?
Yes, ma'am.
Okay. So I have stage 4 breast cancer. I'm 35, And I just want to, like, all of this was really good information, but I just want to know about the loopholes. Like, I've worked my whole life, and I elected long-term disability when I was at my job. I went to the doctor always to get seen and checked about my lumps, and I was told I was too young, and they never, went forward with anything because I wasn't old enough to, I didn't have the coverage in my insurance because I wasn't that 40 age yet. That's one loophole. Another is later on, I started with stage 3 breast cancer in 2018. It just turned stage 4 this year. So through my long-term disability, I was able to get that, but it wasn't until like I get my death sentence at stage 4 that I was awarded my Social Security disability. And in that, I now have to pay my long-term disability back for what they covered while I didn't have Social Security. And now my financial situation from me having money from disability has prevented me from getting Medicaid. I took all the steps that I was supposed to. I worked all my life. I elected every part of coverage that I was supposed to. Like, how do we get around these loopholes? How do we inform people about these loopholes, once we do have the insurance?
Oh, Tanisha, do any of the panelists have a thought for Tanisha? But thank you for bringing that to our attention. Mark?
Yes, ma'am.
I wish there were, simple answer to it, but here's the place to go. But it is maddeningly complex. And, you throw the Medicaid gap in top of everything else that people have to deal with in terms of different programs, having different qualifying characteristics, and there's not sort of a bundled treatment. So I'm sort of being up in the ivory tower, unfortunately not plugged in enough to know where best to get advice, or navigating is often the term, navigating all this complexity. But Cindy, any thoughts about a social service agencies that could help?
Don't off the top of my head. I think that we know that this is an ongoing challenge for folks, that, there are, the rules are, I guess I'll use the word flexible, that you get in and then suddenly something moves that you didn't expect, and you are surprised by it. And it is something that I think we need to make sure is part of this. I don't think that we should move ahead and say, we just, have expansion of Medicaid in North Carolina, that's going to solve all the problems. That, because it isn't. Tanisha raises really good issues that this would not really address, that there are other ways that you get tripped up by the system, and that we need to think about those and focus on those, rather than just assuming that once expansion's in place, we're going to, that we'll have solved the problems. Tanisha, any of us could be you right now. And that, I think, has, put all of us a little bit, made us a little bit speechless right now, because I could be you. I could be in your shoes right now with exactly those kinds of unknowns as I walked into a treatment that, was new to me, that I was overwhelmed by. So thank you for sharing your story. It was personal, and I'm sure it wasn't easy, but it helps us be focused on more broadly, what is it we need to put in place as we go forward. And so thank you for being willing to talk about it.
Yes, thank you for listening to me. I just wanted to kind of bring that to attention. I know, like, I can't do anything that you big shots can, but I just wanted to make that, like, if I even knew about it, it would have helped out a lot. So, just the awareness of it, can help in a major way for the people who go through these things.
Very good. Jamie, do you have anything to add?
Yeah, I do. And I echo the sentiments of everyone in the audience in terms of Tanisha's case. I think this highlights a very important issue. We've made individual consumers of healthcare, we put them in a position that forces them to be the expert on coverage and loopholes and exceptions. And we don't do that in any other consumer space. We would have people who are advising and, as Mark said, navigating people through these decisions. And even though you might have employer-based insurance, your employer-based insurance may carve out lots of different diseases and treatment options that even though you think you have coverage, you may not. And if you think about the reason, the original reason for the Affordable Care Act was because there were a number of people who had insurance, but were, at the time that they needed it most, were underinsured. Their policies didn't cover the basic things that they thought they were going to get. And so this has led to any number of different instances where people are left in a lurch and can't navigate a system that, even as a medical professional, I need help from my friends who are other professionals if I'm in the healthcare system trying to get care. And so I don't know how people who have low health literacy or regular people navigate the healthcare system, because it is confusing. Not to even think about the idea of disability and the combination of Social Security on top of that. So I feel that, you know, sort of angst of, I did all the right things and I still find myself in this predicament. And I think it's because we've adopted and held on to this employer-based insurance model that really, you know, is a relic of the past and is not serving us well at this point.
Thank you, Jamie. Tanisha, thank you very, very much for being brave, and take care of yourself. Next, a difficult issue to move on from, but next I'd like to call on the Vice Chair of Care for Carolina, Sarah Jacobson. Sarah is the Government Relations Director for North Carolina and for the American Heart Association, and a longtime partner of Care for Carolina, and a very smart young woman. Sarah, take us through some of the policy opportunities that we have in North Carolina.
Thanks, Peg. And I'll just say, Tanisha, I was really affected by what your story and what you just shared. And thank you for being vulnerable and sharing that. And I will also just say the fact that you have to navigate this situation while you're, you know, dealing with stage 4 breast cancer, like, is really, really horrible. And it just shows, it's really unfair that you would have to do that while you are, you know, fighting for your life and having to navigate the healthcare system and disability in that way. And I think that's really why we are all here, and the importance of changing this system and making it so that we ensure coverage for everyone, and that we don't have to, people don't have to deal with the economic calamities that come when we have a health issue. We should be able to take care of ourselves and not have to worry about that. And so many people in North Carolina, in Forsyth County, and in our country have to deal with, you know, we know that medical issues are the number one reason for families' personal bankruptcies. And to think that that would happen because you have cancer or a heart attack or an accident is unconscionable. And so that is why we are all here. And it really shows the importance of this moment we have right now to leverage this opportunity that we have to change our healthcare system. And as everyone was saying, this is not the only thing, you know, closing the coverage gap is not the only thing for us to do. There's a lot more to do, but we have an opportunity right now where we can take that step to expand quality, affordable coverage to now over 750,000 North Carolinians. Thank you, Tanisha. Thank you for sharing, and we can try to follow up and see what else can be done.
Thanks.
This would also help ensure that our frontline essential workers have access to timely testing and treatment. Oh, thank you, Haley. Yeah, this is the slide. We have an opportunity to strengthen our healthcare system by reducing the amount of uncompensated care that we've heard about how much this negatively impacts hospitals and our own premium costs, even if we are not in that gap. We also have an opportunity to provide a lifeline to struggling families, which is only increasing right now. And we can do this with 90% of the funding coming from the federal government on taxes that we already pay, which Mark Hall did such a great job of talking about that. We are already paying those taxes. It's just going to other states. And so there has been a lot of proposed legislation in the past legislative session. And so I'm just going to talk really quickly through a couple of those bills. So we have House Bill 655, North Carolina Healthcare for Working Families. This would bring down those 90% of funds, and it was a bipartisan bill. So Representative Donnie Lambeth from Winston-Salem was a primary sponsor on that bill. Representative Lee Zachary from Yadkinville was a sponsor as well. It ended up passing out of the House Health Committee with a 25-6 vote. It actually passed out twice. I was on maternity leave when it passed out twice, so I don't remember why that happened, but I know it passed out twice. There was a lot of support. And then House leadership promised a vote on the floor, and we were never given that vote. So then we have House Bill 1040, Healthcare for Working North Carolinians, which really is a straight Medicaid expansion. Representative Derwin Montgomery and Evelyn Terry from Winston-Salem were both co-sponsors on that bill. It was also never given a hearing. And then we have House Bill 1104, Access to Affordable Health Coverage for All. Representative Derwin Montgomery was a co-sponsor on that as well. That would provide premium tax credits for those in the coverage gap. And this bill was never given a hearing. So the legislature could close the coverage gap tomorrow. This is something that they are perfectly capable of doing. And we know from the conversations we heard today that this need could not be any greater. Right now is the time for the legislature to act. And I think 2020 could be a watershed year for the way we look at healthcare and what we do for people in terms of accessing healthcare. Next slide, please. So we also know that North Carolinian voters agree with this. Care for Carolina funded a poll at the end of August looking at voter support on this issue and saw very interesting results. Next slide. Across the state, 75% of voters, so that's 3/4 of voters, support closing the coverage gap. Only 16% oppose. Next slide. So this support holds up across every demographic, across the political spectrum, across ages, across gender. This is truly not a partisan issue. If you look at the different graphs on this chart, you see between the political parties, ages, there is wide support and across the state, rural and urban. We also learned some very interesting things about voters' perception of COVID. Voters believe that the impacts of the pandemic will be long-lasting. North Carolina voters identified COVID-19 as the top priority issue facing North Carolina. All the more reason that it is critical that we move on this issue now. We know that closing the coverage gap can help North Carolina improve access to testing and treatment of the virus. In addition, 1/3 of voters in North Carolina are concerned about their own family's access to healthcare during this pandemic. So we can surmise from that people are feeling more vulnerable because of job loss and the threat of getting ill from the virus. And this is impacting many families in our state. Next slide. We also conducted polls in a few North Carolina Senate districts, including District 31, which includes Forsyth and Davie County. Next slide. So we found overwhelming district support. 68% of voters in District 31 support a legislative solution to close the coverage gap. So that's the bar all the way to the right. And only 14% oppose. And as you can see across those different bars in the different districts, this is very widely supported from district to district, as we saw from the statewide polling as well. So we also know that 38 states have already done this. In particular, Missouri and Kansas most recently passed to expand Medicaid by voter referendum. We can't do these kinds of voter referendums in North Carolina, so our state legislature has to be the ones to decide to do it. So we know that it could not be a more critical time to close the coverage gap, and now is the time. So we hope you will, in your capacity, talk to your state lawmakers about this issue. They could come back in session tomorrow if they wanted to. This is something they could do very quickly and easily. And we know there is bipartisan support in both chambers on this issue, but it has not come to a vote. So now is the time. Thank you, and I'll kick it back to Peg.
Thank you, Sarah. Thanks to each of our panelists. You all did an amazing job. I see that we have our first question, and then, so those of you who want to ask a question, go to the participants and raise your hand, or you can put it in the chat box. Sarah, this looks like it was a question for you, but I'll also ask, I know Mark has some opinions on this as well. So this is from Paula McCoy, asking, with so much support across the spectrum, what is the key issue that keeps North Carolina from expanding?
Well, I'm happy to start, and Mark, then if you can pick up and probably fill in some blanks, that would be great. And there's not really a good answer. I really wish I could tell you why. We know we have bipartisan support. As we just talked about, there is widespread support across the state among voters. So there isn't really a good reason that we haven't. Some of the arguments we hear is about, the first one is about money, that it would cost the state a lot of money. We hear that a lot. The problem is that doesn't fit with what the legislation actually says. So the federal government would cover 90%, and the additional 10% could come from other revenue sources. In other states, they have covered by hospital assessments. And so to reduce the 90% would take a change at the legislative level, at the federal level. We know there's not really interest in doing that. And this is very similar to a lot of other federal programs that have a state share and a federal share, that, we don't not fund CHIP or transportation funding because there is a chance, in theory, at some point in the future that the federal government would maybe not fund it. We would know, you'd have a lot of lead time if that was ever going to happen, and it's very unlikely. So that's one of the arguments we hear that doesn't really hold up. We also hear, really a focus on who is benefiting from closing the gap, and ask, why should we help childless, able-bodied adults? This is also really not an accurate description of people in the gap. We know 63% are working. Many of these people are in our front lines in vulnerable positions, especially right now. And in childcare, nursing, construction, all the things that keep North Carolina moving. And about a quarter are parents, because many parents just don't make little enough. You have to make very little money to actually qualify for Medicaid. And then the last argument we hear that doesn't really hold water is that Medicaid would be detrimental to those with intellectual or development disabilities and their ability to get on a wait list, or a lot of those people are on wait lists for longer term care. So a lot of those folks are actually already on Medicaid, and this is a very separate program, managed, of course, by the same agency, but they typically already have coverage, and expanding Medicaid would not take away their ability to get that care that they need. So those are some of the arguments we hear, and others may have thoughts on why else they think this hasn't happened yet.
So Mark, additional thoughts on this?
Yeah, so Sarah's exactly right. Just none of the arguments hold up. I mean, they sound like, well, plausible arguments, but you give it a moment's thought and you can just, it's just, distracting, talking points. So I just have to think, I mean, the Republican leadership in the Senate won't even discuss the issue, won't even bring it up for, debate or consideration. And so it just, there's no other answer other than sort of raw partisan politics. Just, we don't want, the leadership, Republican leadership in the Senate doesn't want to have its name attached with anything related to Obamacare, and doesn't feel like it will be punished by their particular constituency in taking that position. And so I don't think anything's going to shift unless we see voter sentiment really bringing pressure.
Very good. Jamie, anything to add?
No, I don't think there's anything to add, but I do think the presentation I made in terms of the history and the historical perspective is informative in terms of thinking about the justification for some of the choices. And to Mark's point, if you use the word Obamacare, that leads to one perception. If you use Affordable Care Act, it leads to a different perception.
I agree. We have found, I think you will notice that we are using the term closing the coverage gap, and that messaging is for a reason. There are people who are dead set against expanding Medicaid, but they have signed on to bills to close the coverage gap. So you are spot on as far as it can oftentimes be simply about the terminology. All right, I don't see any other questions in the question box, and I don't see any hands raised. Cindy, I wanted to tell you one of the things that we have heard, because you run probably the largest private charity in all of Forsyth County. When we go to extremely conservative legislators, they say this is not the role of government. It should be the role of private charities to take care of these people who are sick, or to find them some kind of solution. What would you say to that, or what do you say to that?
My response to that would be that this is a bigger issue than private charity can address. I think that, medical coverage is a right, not a luxury, and the ability for it to be addressed through private charity is really, frankly, we don't have the resources to do so. There isn't enough private charity to create a system that covers everyone in our society that doesn't have coverage today. I think that one of the, because I was muted during the earlier question, when we were talking about what is the holdup at the legislative level, You know, I think one of the things that we need to be incredibly vocal about is these are not people who are not working hard. They are every day. And, you know, the fact is that we have a medical system that is tied to employment. And so an employer makes a decision about whether you're going to have medical coverage or not. It isn't being made by any more egalitarian way. And so I think that that is something that we have to make sure that we keep saying over and over again, that these are hardworking folks who don't make enough to pay and aren't supplied it through their employer. And I think that it's hard to object to wanting to make sure that people who are working every day are going to have coverage. So I think that is one of the hang-ups that I hear when we talk about it at the legislative level, especially on the Republican side. But there is not enough money in the philanthropic sector to be able to provide ongoing health care of the kind that having an expansion of Medicaid would offer. And so it isn't really a viable answer.
Very good. Jamie, I was going to ask you, when you were talking about the difference in health outcomes, have you been able to, and this, I don't mean to put you on the spot, but can you, or are there methodologies to quantify the number of people whose health could be improved? I mean, could you actually put a dollar figure on that? Is that something that epidemiologists can do? Or is that an actuarial question, or am I just crazy?
No, you can look at different populations and actually match for various characteristics and isolate groups of individuals who have access to insurance compared to those who don't, and have all other characteristics controlled for, comparable. And you will see that there is a difference in health-related outcomes. There are still differences by race often in those types of situations. So if you take the VA system, for example, Veterans Administration, right? So theoretically, all of the veterans have access to a healthcare system that's a very good healthcare system, but you still see some disparities by race, even within a fully insured group of people who have access. But those individuals who are Black veterans will have better care and fewer preventable diseases and deaths compared to individuals who may be of the same age and race and other socioeconomic demographics but don't have access to insurance. So you can clearly isolate that effect.
Very good. You bring up the issue of veterans, Mark, because you are really started this conversation in North Carolina on veterans and the number of uninsured veterans in North Carolina. Can you tell us, I think people do think that if you served at all, you can go to the VA or you have life-term TRICARE, long life TRICARE. I have TRICARE. I never did anything. I happened to marry a naval retiree. And so I get something that people who actually got shot at never get. So can you tell us a little bit about the status of the uninsured veterans and why kind of our conventional wisdom may not be correct?
No. So it is misleading in the sense that veterans health care, you assume it's everyone who served gets full coverage, but they only get full coverage for service-related injuries. So if just for sort of ongoing health needs, the Veterans Administration tries to do what it can, but it has limited funding for those other areas. And so the funding is kind of spotty, and it depends on how serious the need is and you know what that year's budget is like, and the eligibility goes up and down accordingly. So essentially, if your health needs are not service related, there's no sort of guarantee of VA coverage. Maybe not.
Very good. I see a question in the chat box, which I think is rhetorical, from our friend Dr. Meg Malloy. Do the same legislators who think that healthcare should be covered by charity, do they want that for people on Medicare too? I have a feeling, knowing the age and demographics of most of our legislators, that Meg, they would respectfully decline your option. So I think I haven't heard that yet. I don't think we've come to that place yet. Well, I will ask any of our panelists if they have any closing remarks or any last questions. All right. Well, I thank Mark. I thank you. Jamie, I thank you. Cindy, I thank you. And Sarah, I thank you very much. And Sarah, I have heard you speak many times, but you were fired up today. I think Tanisha helped put this in perspective for all of us. We really appreciate those of you who've attended this virtual forum, and we want you to stay active and involved. In case you haven't noticed, we have an election coming up. Care for Carolina does not engage in electioneering, but if this is an issue that is important to you, important enough to you, then ask the candidates in your area what they think about closing the coverage gap or expanding Medicaid, or whatever language they feel comfortable about doing, and ask them, will you do something either this year or next year, if you are lucky enough to be reelected? And then give them the face, because some of them may not be lucky enough to be reelected. Erica Palmer-Smith, who is our director, will be in touch with each of you tomorrow or the next day with some follow-up materials. So resolutions that you may want to sign. If you belong to a church or a community group and they want to sign on in support of this issue, we have all these tools available. And so Erica will push all that out to you. She will also send you county-specific data for Forsyth County, so you actually know what's going on in your county and how closing the coverage gap could actually cover so many people in Forsyth County, as well as give it the economic boost that Mark talked about. Jamie, your presentation really knocked me out. I think of myself as a caring person who has no prejudice, but clearly being one person and thinking that of myself is not really the case about what's going on in our country. So thank you for making that very, very clear to us. Last remark from Meg Malloy: if you can help increase the voices who support, please go to the Care for Carolina website and click on Act Now. You can sign on as a business, a civic, or a faith leader, or join Care for Carolina as an organizational member, or you can sign on as an individual. And a number of the people that are on this call, we know, have signed up, and we want to make it more and more, because Forsyth County is a crossroads, an important crossroads. You have a big Senate chair who is chair of the Senate Health Committee, who is someone who has not been inclined to listen to us yet. And you have a chair of the House Health Committee who has been a leader in this. So to all of you, I say thank you. And I think, Haley, we are adjourned. Thank you all very much. Take care.
Thank
Bye-bye.
you.
Thank you.